Hello, my name is Sarah Wheaton. I'm Senior Health Policy Reporter with Politico, and thank you so much for joining us online for our Spotlight event today, Prevention and Patient Empowerment, Who, When, and How. Now, obviously, for those of us who follow health policy closely, it's a very big day with the race for the European Medicines Agency ending today. But as a sign of how important prevention is, we're taking some time out to discuss that today. First, thanks to our partner AbbVie for making this event possible, and for those of you who are watching online, which is everybody, we're here speaking to you from the European Parliament today. We'd love it if you could tweet to us. You can tweet us your question with the hashtag PreventionWWH. One more time, that's PreventionWWH for prevention, who, when, and how. And now I'd like to introduce Mary Harney. She's the chair of the European Steering Group on Sustainable Healthcare and the former Minister of Health in Ireland. Thanks, Mary.
That's correct. Well, I'm delighted to be here this afternoon to represent the European Steering Group. It's a privilege for me to be the chairman of what is a multi-stakeholder thought leaders group representing patients, academia, policymakers and health providers. And our remit is to look at the sustainability of the European health system and see can we come forward with suggestions for improvement. We don't have all the answers, but we've worked very hard to look at innovative, tangible ways of adapting the European system to deal with the current challenges. As we know, the European healthcare system is facing unprecedented challenges because of the ageing of the population and the rising incidence of chronic illness. Our healthcare systems were established to deal with acute episodes of care, and more they have to deal now with chronic illness. We need to change the healthcare system if they're going to be able to cope with the huge demand on their services. And these unprecedented challenges will not be addressed by the status quo. They do need innovative thinking, they do need forward-looking proposals and policies, and above all else, they need people to be practical. We in the European Steering Group have been looking at these issues for a couple of years, and we produced a white paper in 2015 entitled A White Paper, A Roadmap for Sustainability. And essentially that white paper had three pillars. One was to ensure that we engage in prevention and early intervention. Secondly, that we empower patients, and thirdly, that we reorganise care delivery. And all of our recommendations are rooted in 30 different pilot projects that were run across 22 countries. These projects are very innovative, they're very implementable, in many ways they're extraordinarily cost effective. And the good thing about our work is that we're not a think tank. Many people have come forward with recommendations of how to change the healthcare system. This is very much a group that's a do tank based on implementation on the ground. Why did we emphasise prevention and early intervention? Obviously, the ideal is to prevent illness. If you can't prevent it, we must intervene earlier, before more complex treatment is required or before the patient is longer out of work, costing the welfare more money and also reducing productivity. So early intervention, in addition to prevention, has to be the basis on which we reform the healthcare system in Europe. Only 3% of our budgets at the moment are in this space. 97% of the budget is in treatment of illness rather than health and the prevention of illness. At the moment, by 2030, 40% of Europeans will have a work-limiting chronic illness. At the moment, it costs 300 billion a year, chronic illness, or 2% of GDP. It's an enormous price to pay for not intervening earlier or preventing the illness in the first place. Clearly, you can't have prevention and early intervention without the involvement of patients. Patients need to be empowered, to be more knowledgeable, to be more health literate, and to be more involved in the management of their care. And we feel very strongly that this is essential if we are to make the healthcare systems in Europe sustainable. But prevention and early intervention won't happen on its own. Healthcare professionals need to work with patient organisations. All stakeholders need to be involved. So I'm very pleased to be involved in this conversation today. It's close to our hearts. Tomorrow, for example, we will launch an early intervention toolkit. And we will show in that launch that by intervening early with people with musculoskeletal disease, you get 11-to-1 return. €11 is saved for every €1 invested. Sometimes people feel early intervention costs money. We will show tomorrow how it saves money. So we hope that people will watch us tomorrow at 1:30 on politico.eu's homepage. And if you want to hear more about the European Steering Group on sustainable healthcare, you can log on to our website, www.sustainable-healthcare.com. So it's a real pleasure to be here. I'm looking forward to the discussion. It's an area that I think we need to place much greater emphasis on if we want to have a European healthcare system that's able to meet the challenge of providing quality healthcare in a timely fashion, accessible to everybody, which I think is the hallmark of Europe. It's one of the values that we most aspire to in Europe, and unless we change the way we provide healthcare by implementing more tangible initiatives around prevention and early intervention, we are not going to be able to provide that healthcare system that we all aspire to.
Thank you so much, Mary. And now I'd like to welcome our panel and dive right in with one of those obnoxious, oversimplified journalist questions. Mary kind of addressed a lot of different layers of the healthcare system that can be involved in prevention, but bottom line, in one word, who is most responsible for prevention? Is it the health system and governments? Is it patients? Is it health professionals? Rokas Navickas, who's the scientific coordinator of the Joint Action for CHRODIS Plus, where do you fall on that?
Well, thank you very much. It's a great question, and the responsibility is a shared responsibility. We have patients and the medical community, which is responsible for the prevention. Based on the data, which is widely acceptable, widely available, we have many evidence proving that simple things like smoking, physical activity, and not having obesity, huge factors leading to chronic diseases. US being one of the examples where loss of physical activity and eating habits are responsible for increasingly widely spreading obesity, which is...
So those sound like sounds like you're saying patient responsibility is the bottom line for prevention.
It's the first step, I would say, which probably starts from education at a very early ages at school, and then carries on throughout the life cycle. However, medical community, they have a very strong impact there as well, starting with great, well-designed and now widely available studies proving that one or the other preventive measure is of high importance, and obviously then the medical personnel emphasizing what the patients should actually be concentrating on.
Susanna Palkonen, from where you sit as a board member on the European Patients Forum and as the director of the European Federation of Allergy and Airways Diseases Patients Associations, are patients the first step in prevention, and is the main burden on them?
Actually, I think what we are talking about right now, usually in the debate, these are so-called lifestyle factors. But I would like to take us back in that a little bit, because actually we should be talking about, like Mary said, patient empowerment, and that is a shared responsibility. And the prevention cannot fall on the shoulders of a single individual in our modern society. We are susceptible to air pollution and all kinds of things. The healthcare structure and prevention, it's not really necessarily integrated, because many doctors are not incentivized to integrate prevention into when somebody comes into their clinic. It's very much a shared responsibility, and empowerment means that you yourself become active, but you cannot always become active. For example, if you receive a very depressing diagnosis, and suddenly all the burden is on yourself, self-management. Now you have to stop smoking, do this, do that. So we have to be empowered as patients to work together with the healthcare professionals plus the environment and our community in order to become active preventers ourselves.
Well, things like the environment, doctors and patients by themselves can't really do anything about that. That sounds like government has a lot to do with this. Karin Kadenbach, you're a member of the European Parliament from Austria. You sit on the Environment, Public Health and Food Safety Committee. So it sounds like it's on you a bit.
Well, I think, as Rokas said before, and it was mentioned again, it's a shared responsibility. And shared, for me, starts that on the one hand, you need the political framework that makes it possible for people to be empowered. For me, one of the big things is health literacy, so that you really know what's good for you, what's good for your diet. I mean, people know that physical activity is good for them, but very often the circumstances to live in don't make it very easy to fulfill all these expectations. So it's more, what we have to do is forget the siloed thinking that we right now have, that there is health and there is environment and there is workforce and there is finance. It's all goes very close together. So we have to look at it, we have a more approach from all policies. And so that's why I really think it's very important that we keep in mind, we have in the European Union this thinking of health in all policies. So it's really, it makes a difference how housing is, how education works, and it also has an influence on our health. So I think it's not the patient alone, it's also society who is responsible for this healthy possibilities. They have to make a healthy choice. You have to have the information. So it's the European Parliament on, let's say, labeling foodstuff, but you have on the other side, we have to have the possibility to get best medicine. So it's a question also of better access to health in all member states to fight health inequalities. So I do think there's a lot that we can do on a political level to set the framework, to have in some questions also legislation. And it's the combination. I wouldn't only say health in all policies, it's also health in all politics. It's not only a question of the European Parliament or the national parliaments, it's also a question of how health issues are lived on a community level. For me, it's also an obligation for the unions to fight for a healthier workplace. So I think it's a shared competence and a shared responsibility in all the fields.
Please go ahead, Susanna.
Thanks for that. I wanted to add to that since my day-to-day work is in a patient group who is representing people with allergy, asthma, and chronic obstructive pulmonary disease. So from the very beginning, we were all the time concerned about prevention at the same time. COPD is caused by smoking, so you have to take active prevention attitude yourself as a patient. And then air pollution, food labeling in terms of food allergy, and all of these regulations and what is happening around us is affecting these patients. And that's why one of the aspects of empowerment that I mentioned and Mary mentioned is that groups like us and our members and patients with the diseases that are caused by environment can also be part of the policy-making process on environment. And that's one aspect of empowerment. The other is the individual patient, but that's another one. Patient groups being part of the political process.
And I want to drill into one thing that might be a source of confusion for some people. There's been some mention of prevention within the context of chronic disease, and CHRODIS is very involved with dealing with chronic diseases. But, well, if it's about prevention and you've got your chronic disease, isn't it too late for prevention at that point?
Well, we have few steps where we can actually approach the prevention, and I would like to mention the really big joint action which is happening right now, which is CHRODIS Plus. It's a joint action funded by the EU Health Programme, and its budget is over 6 million euros. It involves 21 countries and 45 associated partners. We are working on chronic diseases, in particular trying to identify the best practices throughout the world and then support the members to actually implement those practices into the actual life. And that covers after you have a chronic condition as well as before. When we're talking about the period of once you have the chronic condition, we have many other things following the chronic condition. Those are repetitive admissions or readmissions to the hospitals. Those are decreased life expectancy and decreased quality of life. Now, I would like to share one publicly available trial Stanford University did a few years ago, where they followed up Runners Club for about 20 years, trying to understand if you can postpone the disability once you have the chronic condition. Interestingly, they followed up the veteran Runners Club as well as the general community, and they found that by actually running continuously, you can actually postpone the disability despite having a chronic condition by about 10 years. So that's why it's really important to not only concentrate on prevention before you get it, but also on prevention of side effects of the chronic condition. One other thing what CHRODIS is working on is not just single condition patients, but also multiple chronic condition patients. So we have a lot of patients with multimorbidity, as it was said today, that more and more diseases which were fatal some time ago now are curable, and people tend to live long with 1, 2, 3, or 5 chronic conditions. What we also know is that people with many chronic conditions, they are consuming a lot of healthcare resources. And again, based on US data, a patient who has a single chronic condition, he visits his medical care provider about 4 times, on average 4 times a year. Patients who have 5 chronic conditions, they visit their medical care providers about 14 times a year. So they are consuming a lot of healthcare resources, which is not bad as such. However, if we look at the outcomes, we see that despite them using all the resources, which is up to 74–75% of the whole lot, they're having the worst outcomes. They're having the shortest life expectancy, the poorest quality of life, etc., etc. So we need to combat that somehow, and that's what we are doing as part of the CHRODIS Plus joint action. We're working also on multimorbidity, on multimorbidity care model, which has been identified as a good practice care model combining 16 different components from the studies done all over the world, and we're trying to implement those across different healthcare settings. We're covering 3 different countries with multimorbidity, so we're going to be implementing that in Italy, in Spain, and in Lithuania across different healthcare levels.
And
I totally agree about the need to intervene before somebody deteriorates to a state where they need a much more complex health intervention. And the toolkit the European Steering Group will launch tomorrow will show that if you intervene early with people with musculoskeletal disease and you prevent them having to have more complex treatment and you get them back to work sooner, that can have enormously positive effect. I actually think that we need to not just have health in all policies, but we need to convince finance ministries that good health policy is good economic policy, because a healthy population is more productive. They're less consuming of welfare resources, social protection resources, and they're making a bigger contribution on average to the well-being of the economy from an economic growth perspective. But very often, health initiatives are left solely with the health minister. and it's seen as a big black hole of expenditure. And I think that's one of the tragedies in Europe, that there isn't wider acceptance among other ministries of what's required in order to make the healthcare system more sustainable. And particularly with the rising incidence of chronic illness, as you say, or comorbidity, where people have a number of different chronic illnesses, that's a whole unknown area that's not just costing the individual in terms of quality of life and their family, but it's consuming 70 to 80% of the healthcare resources. So it's not a very good use of the resources, and much more can be done, I think, to prevent the deterioration of patients that may not have been able in the first instance to prevent the illness, but having been diagnosed early, hopefully can prevent its deterioration and have the illness better managed. And that does require a change in how we do provide health services, but also empowering the patients to be more knowledgeable and more literate.
Just going to you, Karin, real quick, to your point about how finance ministers sometimes are not clued into this. You talked a bit about siloing as far as we put environment in one bucket and health in another bucket. In the European Parliament, do the people working on budget development programs, that type of thing, is health on their radar as something that they should be paying attention to?
Well, actually, I'm afraid it's not high up enough at the moment, and we have the same procedure, let's say, with the commissioners. I still do think that the health is not really on top of their daily agenda, but I think it should be in the future. But now I did get the feeling in the last few months, especially with tight budgets all over Europe, that it became a little bit more clear that if you spend more money on prevention, if you really concentrate more on getting people back into on the workplace, that this spending could really help to get healthier budgets. And we had a communication from the Commission a few years ago, Investing in Health, that really showed that every euro you spend before treatment, that every euro you spend on health literacy and on empowering, on setting the frame right, really helps. And that's one question I really sometimes don't understand when we talk, for instance, emissions. Because the whole debate in the Parliament here on emissions was just from the point of view, how will it affect the automobile industry in Europe? How will it affect the consumer as such? And we never talk about how this affect people with chronic diseases, on the air quality, and that's actually the costs we have. It was not just a question of being cheated, it was a question of being endangered. Actually, what we risked was the health of millions and millions of healthy life years altogether in Europe. And that's actually the discussion I want. And I think we're getting a little bit closer with discussions like that today. And well, I do hope that the next debate will start. How will it really affect European people's health?
What needs to happen for those debates to happen? Do we need to have joint committee hearings? Like
we do have joint committees, and it works a little, because especially I've been in the AMIS committee, and there I always mention.
Sorry, what is
the AMIS committee? Was the committee on how you call it?
Oh, don't look at me.
Broadly, what are they?
On the Dieselgate.
I see. Okay.
Right.
And there it was always a question only who knew when what. It was never a question what happened in all those years, how big was the emissions that were additionally in Europe and all that. And I think people, colleagues in the Parliament really started to think things over. We have European legislation not only because we want to produce legislation, but we wanted to have healthier lives, more possibilities. It's the same with, we have the glyphosate discussion right now.
The industry lobbies are much better resourced than the patient lobby,
yeah, that's
unfortunately.
one of the problems. But I think we're directing in the right direction. It's becoming more global discussions, not only health is health and forget the rest.
And Susanna, I know we cut you off before. We'll come back to you because I promise, Susanna, I know you want to jump in there.
No, I just want to second to what ladies here said about the silos. Yes, it's a common problem at the European level, at the country level, but I think it's good news that these debates are happening, that initiative that you are leading are happening, so we are moving somewhere, and it cannot be stopped, I think. I wanted to come back to the issue of how to prevent when you already have a chronic illness. For we as IFA, as the Allergy and Respiratory Group, we are doing this year a project called COPD Move, and we have been completely surprised and been enthusiastic ourselves, seeing how patients who are in severe stages of COPD, how they have taken their lives into their own hands, and they are doing exercise. And it doesn't only prevent hospitalizations and so on, but they are happy. They are happy people, active people in their community. Even if they would be on permanent medical oxygen, they are going to the gym and they are changing their lives. And I think that's the future of being a patient with a chronic illness.
Being able to live more independently, yes.
Exactly. And there must be a saving that you can calculate, I think.
Well, it's not just about the saving, it's about the quality of life for the individual, and what we aspire to in Europe is having a healthcare system that is accessible and delivers high quality. So unless we change the way we do things, we're going to have to contain the provision of the services, because the money won't be there to fund the services as we've known them in the past. And that's one of the big issues. And I think it's great to have discussions of this kind. The narrative does need to change. And I suppose the population at large needs to be more health literate as well, not just the patients. We're all patients. Society is the patient.
And Rokas, you were starting to tell us about some ways that we can actually deal with some of these multi-morbidity patients who are dealing with multiple chronic conditions. Can you kind of walk us through a few of the specific things that CHRODIS Plus is working on?
Sure. Just before I do that, may I just one more point which I wanted to make is I'm glad we're really talking about not just health is health, but health is finance as well. And what is more satisfying is we are not the only ones talking about that. At the World Economic Forum, there was some data shared and discussions had that, in fact, if we take the low and middle income countries, the biggest amount of economic growth accounts for increased life expectancy. So this is the time when we start talking not about health as expenses, but also health as investment. And that's, I think, what's really important, especially keeping in mind that by 2020, it is expected that 5-year-olds will be outnumbered by 60-year-olds globally. So this is something what we as well as finance people need to take into consideration. And coming back to the actual things, what we are working on and how we see it is one of the important bits is that we as CHRODIS Plus team, we are not reinventing something completely new. We are trying to identify what's already available, what's already working and proved to actually be applicable globally, and then try to implement that in a different healthcare setting. So we are talking about small things. If we are taking the multi-morbidity care model, which is very much based on the integrated care model, we are talking about small things such as having a medical team working together, unified, having a case manager who is managing the patient's diseases, problems, managing his admissions, managing his follow-up visits, making it actually seamless for the patient to actually come in and out from the medical center. We are also talking about better collaboration between the medical team members. We are talking about patient empowerment, which is of huge importance, especially keeping in mind the amount of resources we're needing for those patients, keeping in mind the extended life expectancy of those patients with those really big needs for their health. And when we're talking about patient empowerment, we are talking about patient enabling patients to actually provide care for themselves by, let it be ICT or any other means of enabling them, also educating them, which is part of empowerment, and also making sure that the decisions on their treatments, on the way we are approaching their problems, is a shared decision. It's not just something for the medical team. So we basically have the medical team, we have the patient, and then obviously we have the society, which we hope will be playing an even bigger role in supporting the patients throughout. Let it be their families or their friends or the neighbors who are living nearby, and now and again patients can really count on them.
How does that work, pulling in family and friends and neighbors?
Well, we see that the patients especially with multiple chronic conditions, they need a lot of support, and that support ideally should be from the families. But we know that in this busy environment, the families are not able to provide all the care which is needed. So the patients will need to have ICT devices, smart devices which will support them, as well as count on the others who are around them. We have so many social networks, we have so many interconnected people. Now we need to find a way how those interconnected groups can support each other. We don't have a special pill yet, but we feel that this is something what really needs to be worked on, and can actually support not only the healthcare systems, but the patients themselves.
Mm-hmm. And Karin, I know that you wanted to jump in. We've been bouncing around topics a bit, but...
Well, now there are so many things that I would like to add something, but no, continuing this here now, because you mentioned care and carers. I think that's something that we don't focus enough on at the moment, because sometimes it's not only a question of medication, it's also a question of good treatment and looking after the carers as well in the hospitals or in institutions as home. So I think that's something it's right now, at least in my opinion, the focus is not enough on them too. And if I develop new medication or new medical instruments, it should not be only a question how is it, what is the additional value for the patient, but also about what might be the additional value for the carers, for the family, if they have this different kind of medication. It's also a question of financing. That was the one thing I wanted. And the other thing, what I wanted to add is we need more development in the direction of e-health, m-health. But going hand in hand with that, we need to be sure that the data protection is working. So that's the things where, for me, the parliament or the legislation comes in. On the one hand, we need innovation, we need e-health, we need m-health, but we also need health literate people so that we don't leave part of the patients on the way there, because if I don't know how to handle an iPhone or whatever, it's probably very hard to work with an app, but it might be of great help. So that's what I think we should stress more.
And you've actually reminded me of a very interesting that we had come in from Twitter. And just a reminder, you can tweet at us at #PreventionWWH. But that question is, what's the view on the use of genetics in healthcare, and what about the intellectual property of patients of their genetic data? Any of you want to dive in on that one? You're the patient advocate, so I might,
So can you repeat that? Intellectual property of your genetic data?
Yes, it's a little, the question is slightly cut off because it is Twitter, but generally, what are some of the ethical concerns that we need to be thinking about when we're using genetics to determine, what people may be facing? Is this, so we do have these intellectual property questions and privacy questions, but also, is it going to leave patients vulnerable to being required to do things that they might not want to do?
I think it's more, I don't want to go into ethics of that, because people have different beliefs, and rightfully so. I would like to turn it into information about what you are giving your data into and what is going to be used. And is it a flexible consent that you are giving for your data, or is it a one-time thing that you are participating in this clinical trial? I give my data to that, and that's the end of it. So if we talk about the kind of flexible consent, then it would be fantastic in the future that you would have a feedback mechanism. Your data was now used for XYZ, and this study will be finished in 5 years, and then we will give you the results. So for me, it's more about information on what you are giving a consent to, because I believe that patients are very interested in sharing their data if they know it's going to benefit not necessarily them, but also other patients, their children and their children in the future. But this system is not organized and is fragmented, and it's not shared within the EU. But in principle, I think patients are very, very positive. Just as long as nobody can come back to you that it's used in an improper way, your data, when you want to share it.
How do you see data playing into your work?
I think it's extremely important to understand that having the data is one thing, and it's extremely important for having data available to make good decisions. However, it's equally important to be able to share the data which you have, so that you enable others to actually take as good decisions as you can take them. So I think we have to understand that. However, before going into genetics, we are talking about a lot of data which is available already these days. And what my colleague just said, that we are at a time when we're still not sure how to manage the data available in a most secure and accurate way. True. So we need to make sure that we do our homework here before we take the next step. However, I'm a great believer that genetics and epigenetics will be providing us a lot of new tools to be dealing with chronic as well as acute diseases.
And back to some more contemporary tools. You mentioned sort of the issue of there might be apps, but people might not know how to use them, so they don't necessarily do any good. And Susanna, I understand you know a little bit about what it takes to make apps that actually work.
Well, not personally, but I would like to emphasize that apps for chronic conditions, if you think about that, they should be a tool for years to come in a chronic condition. First of all, they need to be developed together with those who are going to use them, and that is patients and their healthcare professionals. But unfortunately, at the moment, it's not very easy to know if you get a chronic condition that, okay, this is the app that I should go for. Of course, it's a free world and everything is out there, but what is it that is really going to help you to self-manage the condition? There is one example of an EU-funded research project from Horizon 2020 called My Air Coach. And it's about asthma, and it's developing at the final stages of developing a sensor-based device that the patient is wearing, that is going to give feedback both for the patients directly, but also to their healthcare professional. And we hope it has been developed together with patients, that we hope that will be one tool for people with asthma to manage their condition. So, but in terms of technology, it's a huge opportunity for patients and for healthcare professionals. But once again, we are not able yet to take the full advantage of it.
We've been very slow at I think, adapting to the emerging technologies. Only 10% of European hospitals provide any health services, which is incredibly low, particularly for people that live in remote areas. So the system is very much organised around the professionals and the institutions rather than around the patients. And I think technology will play an increasingly significant role in the future as it does in so many other areas of our lives. Young people are very technology friendly. To go back to the discussion on data, of course Google has more data on all of us than we'll ever know, and people aren't as frightened of that as they are about their health, because everybody values the privacy of their health data. And I think whilst most patients would be willing to share their data, they want to be assured it won't be used against them, that it'll be anonymised, that they won't have to tell insurance companies, etc., that it won't affect their place of employment. So there are many issues that we have to resolve in the data question if we want to use data to the full benefit of innovation. And I think there's huge potential to use data, genetic data and health data, to improve the emerging the therapies that are possible, and information is the key. And there's a lot of information there, but it's not in a usable fashion right now. I think that will change, and hopefully we'll get the regulation in a practical form that will facilitate the greatest use of data for the benefit of patients and society.
And Another note on new technology, something that caught my eye out of the United States last week is the Food and Drug Administration just approved a pill that patients can swallow, and it will tell their doctor whether they're taking their pills. And I'm just curious around the table if you think that European or patients from your particular member country would embrace such a pill, if doctors would embrace using such a pill. Let's start with you, Rokas.
This is a huge issue. I think this is something what's groundbreaking. However, we have ways of proving that one pill or the other is being taken, which is not applicable to all the pills which are available, but some are. If hopefully that will help to push the rate of amount of patients who are taking the advised pills up. I'm for it, and I'm hoping it'll do the job.
Would you want to see something like that approved by the EMA?
Well, actually, so far, I only know, like you, just in the short notes. I really don't know how it works. But I think it should always be in consent. You should know what you're doing, and you should, as Sarah said before, it must be very transparent, and you must be sure that the data is only used for the reasons you give your consent to it. So I think that's the most important. On the other hand, I can imagine that for some patients it might really be very good to have this kind of control, especially thinking of patients with dementia or something like that. It might really help, so that they don't have the feeling every 15 minutes they have to take their pill again. So if somebody can... So for me, all this E and M health is always a question of not either or, but both. I need the techniques, but on the other hand, I need also the advice of a physical person, somebody I can trust, somebody I can talk to, and it's not supposed to be one of the voices in there in the box that's just not a human being. So I do think there is just a kind of intelligence in the future, but I think right now it's human intelligence I would prefer in that case.
From the patient's perspective, what do you think of this idea?
About the pill?
Yes.
Well, it's of course very interesting technological advancement, and I agree in some cases it can be useful, but I would say that adherence, we talk about patient empowerment. An empowered patient will be more motivated and more empowered to adhere to their treatment. So I would rather talk about patient empowerment, but I agree it can be useful in certain cases. However, during this discussion, we didn't yet mention, even if it may sound old-fashioned, the relationship between patient and their treating healthcare professional is a starting point of everything that we are discussing here once you have been diagnosed with a chronic condition, and that is what we need to build on, whether we build patient empowerment or prevention when already being diagnosed, is the most precious thing that you have in terms of health and managing health in the healthcare setting. So that needs to be protected, even if we have the technological advances. Those can enhance that relationship and that trust, but they cannot replace it. It can be electronic contact as well, just as long as you met face to face, but it is really important still to keep that in mind.
In fact, I would say that how I see the new pill, what you mentioned, is actually something what can enhance the relationship between the patient and the doctor. Because from my experience, you do have patients who actually go home with the prescriptions and then they come back and they feel for some reason ashamed to say, look, I haven't taken the pills. And they then, for some reason, the relationship is not there. Where if we have something like that develop, then it's kind of obvious that the pill was not taken, and this enables the patient and the doctor to actually have a normal discussion. What are the reasons and how we can help you? Can we divert it to some other medication, except of just saying, yes, I'm taking it without doing it? So maybe this can actually facilitate the relationship to actually become even better than it is now.
And are there any other areas, as we just have about 5 minutes left, any other projects that you're particularly excited about going on the continent that you think are really good models for how to do prevention?
We are covering most of it in the CHRODIS Plus Joint Action, and how we're doing it. As I said, I'll just repeat myself. We're identifying the good practices. Either is done through literature, and we have done a very thorough literature review during the previous CHRODIS Joint Action, which identified the good practices, willing to identify those and share those with everyone who is interested. We are also going out to the field and trying to find good practices in actual working environment, and we have put them together in the paper, which is widely available through CHRODIS Plus websites. So I'm not willing to stuck here for too long. However, what I want to touch base is once again on patient empowerment, because I really feel this is a resource which is not being facilitated, used. And will have to be in the nearest future. We have looked at a very interesting data based on the whole Lithuanian population. So it's a one-country population data, which we looked at how patients do when they have single chronic condition versus multiple chronic conditions, and how that relates to their requirements of healthcare resources. And interestingly, we found, not unsurprisingly, we found that with age, your requirements for healthcare resources basically just rise really, really steeply. However, if we only look at patients who have single chronic disease, then their requirements for healthcare resources actually stay maintained throughout their life expectancy. So that, in a way, means that if we enable them to look after themselves, and with a single chronic disease they can do it fairly well, they are able to live a good life, to have a reasonable amount of resource usage within any healthcare environment. And it seems like this is the way to go. Obviously, with multiple chronic conditions, we're going to need to support them even more than we are doing now.
But what is the key to maintaining them with just one chronic illness?
Well, those are the other things what we probably discussed about.
Yes.
But from our perspective, what is said that they are capable enough to look after this themselves as long as it is one disease or something not too complicated.
And are well informed and spoken to
Exactly.
at length.
Facilitated,
communication is very important
educated.
between the health professional and the patient. Absolutely, I agree with that.
So we've just got basically a minute left, so I hope you will indulge your moderator in asking the thing that's at the top of my mind, other than prevention, which is tonight the future home of the European Medicines Agency will be chosen. Only 2 of you now are from places that are bidding, because Dublin actually just dropped out of the race this morning.
Sadly,
So
it would have been wonderful.
we can go around. You can either tell me who you want to win, or who you think will win. So let's.
It's a big question. I think for an organization of that size, for them to move, it's a huge deal.
Just the name of the city.
I'll withhold.
Okay.
I'll pass that if you don't mind.
Karen, I know who you're rooting for.
As an Austrian, I really would think Vienna would be a great place, but as Bratislava is so close to Vienna, I think that could be a good choice too. But yeah.
Got it. What do you think?
I will not take a stand. Besides, I'm going tomorrow to EMA, to the Patient and Consumer Working Party. So I just want to say that EMA is an institution which is the best example as an institution that I know on involving patients, empowering patient organizations to be part of their processes. So whatever it is, EMA is the best.
Mary, what do you think?
Well, I don't know the answer, because wearing my former political hat, you never know until the votes are counted which way it will go. But I hope wherever it goes that there's a smooth transition from the move from London. It's such an important agency for the biopharma sector, for patients, for society.
I got to cut you off. I'm so sorry, but I would like to make note that the current elected official gave the straightest answer at the table. So thank you very much. Thanks to Abby for allowing us to have this event today. And thanks to everybody who watched us online and participated on Twitter. Have a great afternoon, and we'll see you tonight.